So I'm going to talk a little bit about subacromial impingement syndrome, and I'm planning on making the case that it doesn't exist, or that at least we don't have enough evidence that it exists that we should probably still be using. Now, I know this is going to be a bit of a tough case to make, probably because it's so ingrained in our profession and other professions. And normally, if you look at how science works, we would get a hypothesis like, okay, subacromial impingement syndrome is a diagnosis of APTA. And before I get there, let's talk a little bit. Let me define it first. So impingement syndrome, it has a syndrome attached to it. Most of the time when I talk about syndrome, and students I've had, I'll say, you can basically just replace syndrome with we have no idea. It's this cluster of signs and symptoms, and we don't really know what's going on, so it's usually very general. I'm going to make the case that actually impingement syndrome is quite specific. It's general in the fact that it doesn't name a tissue. It doesn't say that it's a supraspinatus problem or a bicep tendon problem. It's very broad. It's just structures in the subacromial space. But it does talk about a cause. It says this is a problem that's caused by impingement. So in that case, it's very specific. So really, when we're assessing the evidence, it's really about, is the evidence make a strong case that pinching is the mechanism by which this degeneration happens in the subacromial space? I'm going to make the case that it's not. But to go back, so normally we would say, all right, we come up with a hypothesis that pinching is the problem. And we would test it. We would say, all right, that sounds interesting. We know a lot. Let's withhold our judgment and test it. And if when we test it, the evidence shows that that's accurate and we can make accurate predictions based on it, we'll accept it and we'll move forward. Unfortunately, in the clinic, we don't have 40 years to wait for that process to occur. So we have a hypothesis and we say that makes sense, maybe as good as anything else we talked about. So we accept it. And then as it goes through the generations, it gets more accepted, and we forget to ever go back and look and say, well, what's that evidence say about it now? And then when we do, we look at it as now it's got to disprove what we already believe. And it's really hard to disprove something we already believe, right? There's always a reason why we can make an excuse for the evidence not quite good enough. So to make my case, I want you all to kind of put your hats on as far as we're not trying to disprove subacromial impingement syndrome. We're trying to find if the evidence proves that that pinching is actually the problem. We'll see how we do. I know it's not so bad. So, all right. To do this, here's my outline. I'm going to start out with just a quick review of impingement syndrome. I'm going to spend very little time on this. I don't think it's really important. We've all kind of seen this many times, so I'm not going to go through details of anything on the anatomy or something like that. I'm going to talk about it just in general. We're going to move on to what I'm going to call the direct evidence. So that's evidence that specifically is going to look at is pinching occurring. And I'm going to show that, first off, there's not a lot of evidence on that. I guess it's a hard thing to find. But the evidence that we do have doesn't support that pinching is abnormal. It's normal to have those structures pinch. But because there's not a lot of evidence, it's not a very strong case. Let's look at the indirect evidence. And I'm defining indirect evidence as the evidence that looks at the predictions we'll make based on this hypothesis, this idea of pinching. So if there's certain anatomical and biomechanical factors which increase pinching, we would expect those to be associated with impingement syndrome, patients with shoulder pain. If we have interventions that are probably the most effective at reducing that pinching, then those should be the best interventions to get the best outcomes. So that's when we look at that kind of evidence. It's not directly looking at the pinching, but it's looking at those predictions. And finally, we'll talk a little bit about if we decide or if we say we're going to get rid of this idea of impingement syndrome as being a diagnosis we should use, how does that impact us? And I don't really have a lot. I have some ideas on that, but I don't have a lot of lecture to drive that at. We have a lot of people here with a lot of experience seeing shoulder pain. And I think it'd be an interesting conversation to have. Is maybe it doesn't make sense. Maybe we decide, okay, we get rid of that diagnosis and actually it doesn't change anything. I think it might a little bit, but we'll have that conversation. With me so far? All right. So let's talk a little bit about generally impingement syndrome. So the history, when I looked, and I've looked at a lot of studies over the years. I've been looking at this topic for 2 or 3 years now, and looking at the literature. And what I found is there's a lot of literature on this topic, and which is a good thing, but it's bad in that it's really hard to put it all together and to make sense of it, because a lot of it's conflicting, and you don't necessarily find all of it. You try to find the best studies. But when I was looking through this, 1852 was the reference I kept seeing as the first time it was really written about. I didn't go back and I didn't find that reference and look at it, but it's kind of hard to find articles from 1852. But really, it wasn't until 1970s when Neer started writing about impingement syndrome where it really started to get popular. And this is one of the first articles he wrote on anterior comioplasty plus chronic impingement syndrome in the shoulder. And he went right to, okay, pinching is the problem, so it makes sense that we should go in and cut out structures and make more space with less. And he wrote about that. He wrote several articles in the 70s, and that's really where it started to take off, and it really became part of the common practice amongst orthopedists and physical therapists. And it's led us to a point now where about 44 to 65% of patients with shoulder pain are diagnosed with impingement. So if we get rid of this diagnosis, it's going to affect a lot of our patients. At least they'll have a different name for the disorder, potentially. So it's out there a lot. And we already talked about, this is really about pinching. So the subacromial space, that space, the acromion the top, humerus is the bottom, and we have the coracoacromial ligament kind of making the roof, and we have the supraspinatus tendon, the bursa, the bicep tendon, and the capsule in that space. So pretty broad, but it's pinching of those structures is what we're really talking about. And I'm going to probably shortcut that a little bit and talk about rotator cuff dysfunction. And when I say that, I really mean dysfunction of these structures. The supraspinatus tendon is what we usually see. It's one of the more common rotator cuff muscles bothered. Bicep tendon can be in there as well. So I'll probably say rotator cuff, and that's what a lot of the research does. They talk about rotator cuff dysfunction. So that's what I mean, those subacromial structures. So when we talk about the indirect evidence, we're going to look at a lot of these things that I think are familiar. We've talked about in PT school, we've learned about, acromial shape is very important. So obviously, if in a acromial shape, it would reduce the amount of space we would expect to be related to impingement syndrome. Humeral translation, so the acromion can come down or the humerus can go up. Both situations, you're going to have most likely reduced space. And then I would assume increased pinching. We also talk a lot about posture. PTs love posture. We'll discuss that a little bit. Does the postures that we would think correlate with reduced space, are those associated with impingement syndrome? And then last, we'll talk about biomechanics as well. So all these things are thought to be related to impingement syndrome. Is there stuff I missed on the list? Probably other things. Those are pretty broad. All right, how about jumping out? And I didn't quite go there as much with posterior shoulder tightness. Some talked about that, and what that would be, I think you're in there where you're kind of sliding that humerus forward a little more and then getting more pinching on the anterior aspect of it. Yeah, so there's not as much, I didn't see as much work on looking at its association with pinching, and I'm not going to talk about that as much, so that's a very good point. Let's get on diagnosis for a minute before we move on. So one of the problems with studying this in general and looking at it is trying to diagnose this condition. And multiple studies use either in the ballpark, but similar ways of classifying subjects with impingement. Normally it has to do with anterior lateral shoulder pain. Often the complaint is more with overhead activity. And then some cluster of special tests. And this study by Michener gets the majority of. You have Hawkins-Kennedy, Neer, painful arch. Those are probably the most common three that you see in the research. And then we have MTCAN and external resistance. So I put up likelihood ratios here. I kind of like likelihood ratios. If you're not familiar with them, they're essentially calculated from the sensitivity and specificity. The nice thing about it is it allows us to look at our pre-test probability. We have some prediction. How confident are we that this disorder is there before we start doing these tests? And then we use our little Flanagan's nanogram there and put it in, and we draw a line, and it gives us our post-test probability. So I think it's a little more clinically useful. And in ballpark, usually over 10 is considered a big increase in, so if you have a positive likelihood ratio greater than 10, it's a large increase in post-test probability. And if you're down by the 5, it's moderate, 2 is minimal. And negative is about like 0.1 is a large increase. So give you some ideas of where these numbers fall. And Mr. came up with this kind of cutoff. If 3 out of 5 are positive, you have about a 3 positive likelihood ratio. Now we can stop there, but I'll say we need to look at it a little further. So what is the gold standard that they use to judge these tests by? And the gold standard is usually, in the studies that aren't so good, they use MRI. Not quite as reliable. And the better studies actually use an arthroscope and look at the tissue. What they're looking for is they're looking for signs of rotator cuff pathology or bicep tendon pathology or maybe bursitis. But what they can't tell is they can't tell the mechanism by which that's happening. So they don't know that that's caused by pinching. Yet we're classifying them as impingement syndrome, saying it's a pinching problem. But we really have no evidence, even our best way of diagnosing, even if these numbers were 30 positive likelihood ratio, it would only be its correlation with rotator cuff pathology, not necessarily pinching. So that's my first little bit of ammunition against this diagnosis. We don't even have a good way to assess whether pinching is the problem. So why go that and why go there and why be that specific when we can't back that up? Oh yeah, I forgot I made that fancy box around it, and I was supposed to time it better and say I was supposed to pop up and draw your attention to it, but I missed my mark, so we'll just skip over that. So all right, so let's talk about direct evidence. So when I was looking for this, now like I said, I've been looking at this research for a while, but I haven't been looking at it in line of whether subacromial syndrome made sense. I was looking at literature about it. So when I went for this topic, I said, what is a study that I'd like to find? So the best study would be, well, the most reasonable study I could find, I thought, would be a study that did some kind of measure of the amount of pinching that was going on in the shoulders with individuals with impingement syndrome and individuals without it. And I would expect to see no or little pinching of the asymptomatic subject and lots of pinching in the symptomatic subject. Fortunately, that study wasn't out there. But even if I found that study, the problem is, and all the studies we're going to talk about, is they're all retrospective studies. So these are studies that at best can talk about correlation, but we really can't decide anything about cause and effect because we don't know if any of the changes we see in the individuals who have shoulder pain are the result of the problem or maybe a cause. We don't have that temporal relationship. So the absolute best study I could have found would have been a study that looked at a whole bunch of people without shoulder pain and measured the amount of subacromial contact that was there and categorized them as people with a whole bunch of pinching and those with less and follow them over time and see if that predicted the individuals who were going to get shoulder pain. That would have been the best study to be able to say, aha, if it showed there was increased pinching and those people had more shoulder pain, that would have been the best case for impingement syndrome. That study wasn't out there, unfortunately. And really what I found, all the studies that I could find that looked at pinching were in cadaver shoulders, which to me is not that convincing. But here's a study here by Lee, and he looked at 40 fresh cadaver shoulders. And they put, now if you just take a shoulder and you just place it, gravity's going to be pulling down. We don't have the same amount of force in there. So all these studies try to impart what they think would be a normal type of compression force. This one did about 20 newtons of force through axial compression. They put it through. And I think they had the shoulders, they kept them stable at, I want to say, about 40 degrees of abduction. And they used this pressure-sensitive film. They put it in there, and they looked at shoulders that had rotator cuff damage and those that didn't, and they found the same amount of pressure. Right? Impressive, right? You guys are convinced now? No? All right. Well, I wasn't really either, but I said, okay, that's interesting. It indicates that if you're a cadaver shoulder and you don't have rotator cuff pathology, you have just as much compression as one that does. So, interesting, but not real convincing. This one was a little bit better. This is a study by Yamamoto, and one looked at 7 shoulders, but they at least tried to put compression through the shoulder, I think, a little more like it would be in real life. So they actually they tied strings onto the rotator cuff muscles, and they pulled their tension through those. So it was a little more like real life, I think. They used about 22 newtons. Most of these studies are right around that 20, 25 newtons, and I didn't really quite understand how they picked that number, but they seem to think that was the best number. And then they, in this contraption here in the bottom, they actually had the shoulders go through a range. And they were only looking at normal shoulders, and they found that there was tension. They came to the conclusion that contact between the humerus and the acromion and the structures in between is a normal thing to occur. But that's not abnormal. Everybody has pinches. And here are several other studies. They had the two we just talked about on the bottom, but several other studies that use different mechanisms that all basically found that contact and pinching of those structures is normal. All of them in cadaver. So again, maybe not the most convincing, but gives us some information. Now the study down at the bottom, Papadontalakis, I worked so long. I'm going to get that right. I said it like 4 times on my own. So we'll just call it Dr. P, maybe 2011. This is a review article, and I got most of the studies in that article. They also had several studies, which got me really excited when I saw their graph they had, a chart that talked about studies that showed pinching in normal healthy subjects that were alive. I was like, great, this is perfect. And I went and I looked at these studies, and I was quite disappointed. There were all these kind of normal anatomy review type things. They'd have MRIs and they'd go through these normal anatomy reviews, and then they might mention someplace that they got the pinching, but they weren't really studied. So I didn't even bother putting them up there because I really didn't take the case. But if we put on our caps of we're not going to believe in impingement until that the pinching is a problem, until it's proven to be the problem, I think that these studies don't help in that at all. There might not be a lot of ammunition against this idea of pinching, but they definitely don't support it. Yeah. What is the use of Yep. Yep. So again, I can't say I looked at every single one of those in great detail, so I don't know for sure if they all tried to fix, but the ones I looked at had fixed. The first one didn't even have motion. They just put it at, I think it was 40 degrees of abduction and did the compression. So, yeah. So again, this problem is not super convincing, but definitely gives some ammunition to think that compression is probably not, or pinching is probably not abnormal. Right? And it makes sense. That space is not very big. The small space had lots of structures. So probably the issue is not even that, maybe if pinching is the problem, it's not whether it's there or not, it's the amount of pinching. Sorry. So that's our direct evidence. Not really helpful. So let's talk about the indirect evidence. Again, these are things about anatomy and biomechanics that we think would increase the amount of compression. And then treatments that we think would be the best at reducing the compression. And those should be the most effective treatments. So first thing, we've all talked about this we've heard about this a lot, the acromial shape. So there's 3 types of acromion. There's type 1, which is flat, type 2, which is kind of sloping down, and type 3, which is sloping. And like most things that we like to talk about, it's not quite as simple as type 1, type 2, type 3. There's a lot of debate. There's different ways of categorizing these, and type 1, type 2, type 3 probably doesn't encompass it enough. And there's a big problem with reliability. This measurement is not an easy one to get reliable measurements for. As I looked over the research and tried to look at it as broadly as I could, it turned out it was fairly mixed. There are some studies that say that it's correlated. There's some studies that say that it don't. But I'll go back to, even if, and I'm going to go over put up a chart with a few specific studies. But even if we have this association, all of these studies are, again, prospective studies. We don't know what came first. And there's some data to suggest that with age, acromial shape changes. And it's very possible that some of this acromial shape occurs with degeneration. And so we get more of that. And that would make sense that rotator cuff pathology occurs as we get older more often. So those two might be just in line with each other, may not be cause and effect, and may be occurring because of the same mechanism. And there were some varying articles on that. Some showed that type 2 and type 3 acromion were more prevalent in older individuals, and some questioned that a little bit. So again, it was mixed. So here's generally some of the articles. And again, X-rays where I saw the most problems with reliability. In this first article here, I'm not even going to attempt to say the name. Call it Dr. T and his colleagues used X-ray, and they found, and I'm not going to go through too detailed because a lot of studies talk about, but they found that there was an association that individuals, I think it was 6.2 times more likely to be diagnosed with impingement syndrome if you had this Subacromial. Put it in perspective, smoking was 6.8 times. And there's an also study that talked about rubber tappers. I had to look this up. And rubber tappers had less incidence of shoulder pain impingement syndrome than government workers. And rubber tappers were people who go out to rubber tree plants and tap them and get the sap out of them. Like, interesting. But it kind of goes to these individuals that are very physical labor actually had lower incidence of impingement syndrome than the government workers. Whatever that is, it's just interesting. It was interesting to read. And then we have the other two studies that used MRI, which is arguably a little more accurate. And they both found that there wasn't a clear association with the shape of the acromion and impingement syndrome. And this last study by Payne, this is a little different. They didn't really look at the association. They were just trying to show, does a change in the acromial shape actually increase the amount of pinching, the amount of pressure? And they found it, yes. So again, maybe not the most convincing evidence if we're trying to disprove that impingement syndrome exists, but if we start that we're looking to see that impingement syndrome is proven, this is not supported. We would expect that these hooked acromions should be quite correlated and causative into these problems because they're causing more pinching. And the evidence is pretty mixed. Questions about that before I move on? All right, good. That's the numeral translation. I really had a hard time finding a lot of evidence. One of the things I was talking about a very small amount of motion, so it's pretty hard to measure. But essentially, a subacromial space is about 1 to 1.5 centimeters. So not a lot of room. And we know that just in normal shoulders, it's normal to get translation. So 30 to 60 degrees of active elevation, we have 1 to 3 millimeters of superior translation. Right? And as we get up, and so same thing, 30 to 60 degrees, we have some anterior translation. That normally happens in shoulders. Once you get up further than 90 to 120, you actually usually get less. You get a posterior translation. You move away from that anterior position. And this all results in reduced space. So again, we would predict that if you get more translation, this would be related to shoulder pain. Again, this was fairly mixed. There was a very older study from 76 by Popham used X-rays that did find small increases in superior translation in individuals with impingement syndrome. The other article in 96, same thing, showed increased translation. And then Ludwig in 02 didn't, in using 3D, so probably a little more accurate, a little better at finding this, tracking these very small motions, found increased anterior translation in the individuals, but not increased superior translation. Again, fairly mixed. I would also argue that these are, talked about again, these are prospective studies, they're retrospective studies. So we don't know about cause and effect. I mean, I think you can make a pretty strong case that when you have rotator cuff dysfunction, and Michener did a study on this, found that if you take individuals and they have fatigue of their rotator cuff and deltoid, the amount of translation that occurs increases. So it's very likely, or it's at least as likely, that this could be the effect of the shoulder pain and problem than it is the cause. So when these individuals are in pain, they might have rotator cuff dysfunction, and then reduce their neural drive to the rotator cuff, and the deltoid not produce as much force, and therefore get increased translation. So again, maybe not the strongest evidence against it, but definitely not evidence for it necessarily. Now, the next information I'm going to talk about is, and I'll stress this to you guys, that I've read a ton of articles looking at this information. And this article that I'm going to bring up next is by far probably the best article I've read on this topic. Really well done. The person who wrote it obviously extremely brilliant, and I'm guessing pretty handsome as well. I also hear he's very modest. So this is an article on subacromial impingement and posture. You don't realize it's me up there who wrote it. Several years ago, I was looking for a project, coming in and getting into academics, and having some conversations about this idea of posture and how important it was. And I started looking, and I was surprised that I didn't really see any studies, any review articles that pull all this information together. Because it's pretty complex and it's all over the place. So I started looking at it, and I said, I need a project. Why don't I just start writing something on it? So I worked through, and you notice this is a narrative literature. So there's systematic literature reviews, and there's these narrative or traditional literature. The main difference is, with a systematic review, you usually have some kind of systematic way to rate the articles to decide if they're included or not. And sometimes you do other things with meta-analysis if you want. I thought about going that route, but there's so few studies that I wanted to really be able to talk about this topic as broadly as possible, not excluding it. So when I talked about it, I basically broke it up into 3 categories. And this is kind of similar to how this presentation is. I looked at evidence that was direct evidence, the evidence that looked at static resting posture in individuals with impingement syndrome compared to individuals who didn't have impingement. Again, I would have loved to have found some prospective studies, but they're all retrospective. And then the other category, I said, well, let's look at articles then that maybe will lend plausibility to this idea. So maybe the article didn't have patients with subacromial impingement syndrome or just shoulder pain, or looked at asymptomatic individuals but tried to look at how posture might affect how the scapular moves. And that category. My third category was treatment. What kind of treatments were out there and what was the evidence for that? So I'm not really going to talk about that category today, but we'll look at the first 2. So the first one, the articles that looked at individuals with impingement syndrome and their posture in resting posture. So this is not, some studies would tell in groups to, all right, slouch down as far as you can and move your arm. Sit up as tall as you can and move your arm. I didn't count those in the most direct studies because we expect that to change their shoulder motion. We'll talk about that a little bit. So the 9 studies I found that looked at that, all 9 of them found no correlation between posture and impingement. Now, some of the challenges of this is, first off, posture is not easy to measure. Right? How do you measure posture? What do you use? Do you measure the scapula, the thoracic spine? Do you do broad measures of posture? So there was a variety of different measures of postures in those studies. Impingement syndrome is hard to categorize, too. That's a problem. And none of them subcategorized either and made an attempt. So it's possible that there's a subgroup of individuals that posture does really matter. And maybe they got kind of blended out with all the other data. But it was pretty consistent. The next I looked at, there were 15 studies that were these related articles. And 6 of them supported that there was no connection. So they had some data that kind of went against the plausibility of posture being. And again, we're talking about posture here because posture would likely reduce the amount of space, amount of pinching that's going on, or increase the amount of pinching. 9 studies provided some plausibility. Now that sounds kind of good when you first look at it, but I was really generous when I counted an article as giving evidence and plausibility towards it. And I'll give you some examples. This article here by Bullock, they looked at 28 individuals with subacromial impingement. And they basically told them to slouch down really far and lift your shoulder up. And they said, sit up tall and lift your shoulder up. Well, there's several studies that show that we get 12 to 15 degrees more shoulder elevation because of thoracic spine function. So not surprisingly, these individuals got increased motion when they were sitting up tall versus slouch. Their pain didn't change. They still had the same amount of pain. They still had pain at end range. This was a little bit higher. And how they measured it is they just used an inclinometer on the arm. They didn't even look at glenohumeral motion necessarily. They just put an inclinometer and they said, go from here and do this and do that. Oh, look at your shoulder range changed. So I wasn't very convinced by that article, but I counted it as an article for the plausibility. Now, that might be useful for when we're treating, right? We can still take advantage of that. If somebody needs to reach up a little higher, we can still have them try to get more attention to the thoracic spine, and that may be useful. But it's not necessarily going to treat their pain and dysfunction. Another article by Greenfield, they found an association with overuse injury. So it's very broad. Some of these individuals may have had impingement syndrome. We're talking about shoulder overuse injuries, and they found an association with forward head posture. But again, not clearly defined what the population was. And then this what I kind of just discussed, this Cavesi article. They found that a slouched posture, so if you slouch down, it was associated with increased scapular elevation. Again, so it at least gives them evidence that posture of the thoracic spine can affect the shoulder in a way. So I counted those articles. So again, this prediction that our model of pinching would make doesn't hold up. The postures that we would expect to increase the amount of pinching are not necessarily related to impingement. So I'm trying to build that case. Questions so far? Good. All right, next, talk about scapular motion. So sitting still, static posture is one thing, but we often look at this scapular dyskinesia, right? We see our patients move, and we see their scapula flopping all over the place, and we're like, that doesn't seem right, and their other side's better. And so that's something we'll assess. And we have things like decreased downward upward rotation. So if the scapula is not, Pat, you asked about upward rotation earlier, if the scapula is not upward rotating as much, that's essentially bringing the acromion down and increasing the tension. Right? So we think when we get more upward rotation, that'd be good. And so we would assume that downward rotated scapulas are probably associated with impingement. Individuals have biomechanics that have less upward rotation, they would be more likely to get impingement. Same thing with anterior tilt, and maybe a little less so with increased elevation and increased medial rotation. And those are the things you see in the literature thought to be, proposed to be associated with impingement. Now, I'll say again, the problem becomes is even if we found that these changes occurred, the studies were done looking at individuals who already had shoulder pain versus individuals who don't have shoulder pain and see if there's a difference. And even if there was a difference, we can't make a causative relationship. We know that we change the way we move when we're in pain. Right? If somebody walked into your office and sprained their ankle and was limping, you wouldn't think, oh, that limp is what caused the ankle. You wouldn't go right there. So we still have that leap to make. However, it's still not clear that it's associated. So this is a review article that's fairly recently done, 2013, I believe, by Radcliffe. They looked at 10 trials to identify the scapular motion in individuals with and without impingement syndrome. They essentially found that with upward rotation, 2 of the studies found an increase, 3 said it decreased, and 3 found no change. Pretty clear cut. All over the place. Anterior tilt. 2 increased, 2 decreased, and 1 no change. You see all over the place. The most consistent ones were elevation, people elevated, which I don't know that we can make that a clear association with impingement syndrome, and we can probably understand how that would happen if somebody was in pain. Once they were in pain, they're guarding that, they tighten the muscles up, they elevate, they don't want to move as much. So I think you make a strong case that that's probably, if anything, caused by the pain, or not a cause of the pain. And the same thing with this medial rotation. 2 found an increase, or 4 found that it increased, and 2 found no change. So again, another aspect, another one of our predicting models that doesn't really hold up. And I was surprised by this, actually, because even when I was looking at the literature in this, and a lot of the studies that I looked at from my article, they didn't go out to look at static posture. It wasn't the goal. The goal was to look at scapular motion throughout elevation. But they also measured a resting measure of scapular posture. They talked about it. So I looked at a lot of these studies that looked at scapular motion, and I guess I didn't pay enough attention. I thought it was a little more consistent. It was always like, oh, there's changes. It's consistent that there's changes. And then when I saw this review article, I went, wow, you know what? It is. I didn't realize how inconsistent it was. And one of the problems with all this stuff, with biomechanics and with posture, is in normal population, it's so variable. Like the normal population, the variability of scapular upward rotation was like several degrees of downward rotation to several degrees of upward rotation was the normal range. So it's really, there's not a standard posture, which makes this tough to look at sometimes. So, all right. So that's some of the predictions. Now let's go on to treatment. So we can make certain predictions of treatment that if pinching is a problem, the interventions that are going to be most effective at decreasing the amount of pinching should be most effective. Yes. Sure. No, not necessarily. There's varying studies. Some of the studies would do loaded, would take them at different ranges and say, all right, stop at 20, stop at 120, and go up with using some kind of load. Depending on the model, some of them use 3D trackers where they have the person actually move and follow it throughout the whole motion. So there is variability. Yeah, so they're all, and I don't know that, I don't have them memorized enough to say this and that, but there was definitely some that did a few and some that were stable. And there's also been, but there's some studies like the scapular assistance test. Do you think of that one? So there's a study where they've looked at individuals and they said if we have them do abduction and we assist them with upward rotation, does it give them less pain? And they found that actually helped with a little less pain. That's the mechanism for it. I don't know. And exactly, and that could be it. That could be it right there.
So I don't get took a look at. Actually, George Davis took a look at the most of my patients that came higher up with 150 as well. So.
And they were looking at what for that? They were looking at reproduction symptoms, or they're looking at posture. Yeah. Yeah. It's hard, and partly just because some of it might be just so variable in a normal population. It's hard you have to have a big difference in the groups to really see something significant. So I'm not going to talk, when I talk about treatment, I'm not going to talk about manual therapy because that's muddy in the water. What's the depth? So I'm going to stick with looking at what I think is probably the best bet for reducing this amount of pinching is acromioplasty. Like go in there, cut out the acromion, make more space. That should be really effective over other interventions. And also we can look at exercise a little bit and see how that does. But I'm definitely no expert in acromioplasty, but here's a fairly long list. And every single one of these articles found that acromioplasty was no better than the treatment they compared it to. So it's somewhat good news for us because we're in the exercise business. So you look, 1, 2, 3, 4, 5, 6, at least 6 articles that compared acromioplasty to exercise and found that it was no better. That adding it did not improve outcomes at all. There's another article I have in here that does this, which really bothers me, looking at physical or physiotherapy as the intervention. That's the pet peeve. Like, we're not an intervention. They would look at exercise versus physical therapy. No, that we're a profession. We're not this thing you prescribe. So there's a couple articles that do that. It always gets me annoyed. But really, even this. So look at cuff repair. If they do a cuff repair with or without an acromioplasty, no difference in the outcome. So to me, this is probably the biggest nail in the coffin to say, and there is studies, not a lot. There was a study done by North, I think was the name. They looked at, again, it's not perfect, but they took individuals who were going in for an acromioplasty, and they measured the amount of pinching that occurred when they did passive range of motion under anesthesia before the acromioplasty and after the acromioplasty, and confirmed that reduced the amount of pinching. Now again, that's passive and maybe a little bit different than what happened actively, but they did see that passive motion. So I think it can make a case that this is probably the intervention that's most likely to reduce the pinching, and it really is not any more effective than other interventions. So really, to me, this is the biggest nail in the coffin to say, maybe we got to give up this pinching. If there is pinching, we can identify it. It doesn't predict what's going to happen to individuals, and it doesn't really predict what intervention is best. Well, we're physical therapists, so we'll talk about exercise. Some of them did. No different. Yeah. But if you have two interventions that are different and they respond the same, then you're looking at maybe more non-specific interventions. Like, I mean, they didn't do, which would be nice. So a great study here would be placebo surgery. Like they did the knee. Right? They did a bunch of those at the knee where I think there's been 3 studies out on that, where they looked at if we go in there and clean up the knee, or we go in there and pretend to clean up the knee. We put the scope in, we move it around and take it back out. Those individuals do the same. Right? They both do better. But it goes to show that, well, maybe the improvement is not because of not because of that specific intervention, because of some other cause. And I would make the same case here that if you did a rotator cuff repair and didn't do an acromioplasty, you didn't change the amount of pinching, unless maybe training rotator cuff did that essentially, but you really not changing the pinching. It was there to begin with, and those individuals would do just as well versus doing acromioplasty with it to reduce the pinching. So
you're saying that there's a normal amount of pinching in the shoulder. Right?
That seems to be based on cadaver studies.
There's actually there is a study that actually puts the flexion extension and the flexion in the shoulder that contact there is. I mean, in the case for email translation, could it be less about how much translation there is and actually the fact that there's aberrant movement and not up translation? So, for instance, you haven't put your shoulder in, maybe we do it back.
Mm-hmm.
And so
I saw some articles on it, but didn't spend a lot of time.
So if you're abnormal position shoulder in an anterior superior position, which is probably the slide that you had up earlier showed that use that very normal motion, the anterior translation, and then posterior translation. So that's a painful motion. So if you're starting in a prematurely anterior position, you can't go backwards. You're already anterior, so that normal pinching that occurs will essentially be accentuated.
So what you're getting at is if I can maybe summarize a little bit and make sure I understand, is that you're saying that they're maybe looking at the amount of translation, but they're not, are they assessing where it's starting from too? So maybe it's starting more anteriorly already, so it may even look like there's less anterior translation that's occurring, but it might already be further forward to start with.
So look at the very patient with short-term stack 3, and with later actually it's been even more honed in on what Tyler found in his study, and I think it was 6, that it's not as much to internal rotation rather than foreground. That's a position head starts position. So being physical therapist and looking at movement impairment syndrome, essentially, that's basically what it is. Your word syndrome again, but you have this aberrant motion, which gives us a chance to correct that part of the position. Because someone makes a move at one time, probably not going to affect malposition in the joint. If someone does it repetitively over and over and over again, that's essentially what knee is part of the disease.
Yeah, I mean, I think that's possible. I mean, my read of the literature, what I found was there really wasn't, there wasn't a, like even some of these studies are possible to look at, forward shoulder position and all those things. It didn't seem to be strongly correlated. Now, maybe they're not looking at it right? It's not an easy thing to assess. It's not an easy thing to accurately look at. So it very likely could be. I think what I would make the case is we don't quite have it figured out. So let's not call it pinching when we don't know. When there's a variety of different ways we could look at it. Yeah, it's not. It's pinching is it seems to at least.
And I don't necessarily get it either, because everything not necessarily just the actual ball.
So it comes together.
Which is why Dr. Hawkins actually is working with Chuck Pickett down in South Carolina, actually ultrasound to measure real-time floating and slow motion. That's why we know the best way to actually measure internal rotation. And they're seeing that there isn't much translation in the shoulder that is back because of forward.
Yeah, and that definitely could be a problem. And then the question is still, even if the position forward, is that the mechanism by which is that pinching that's caused? If that's increasing pinching, is that still a mechanism by which the problem is? Is there extra strain on rotator cuff because of that position? Is there other things that occur that increase the amount of stress on those tissues that maybe describe it better? Right? Because it's still not a direct measurement of the amount of pinching. We still don't have that. We still just have, well, this might change the pinching, and that might be related, and it's a little more complicated.
I agree. It seems to kind of fit into that almost beta classification. So it's
definitely
material power identifying it.
Yeah, and that might be a way. It might even be a way that we change. It's not looking at it, sitting a little bit ahead. It's not looking at it as this is necessarily a pinching problem, but classifying people based on some of these impairments and going after them, the ones that maybe make the most sense at this point. And things like posterior capsular stiffness might be some of the things that make more sense. But again, it's still in its infancy looking at it. There's not a lot of outcome studies on it. We don't know how effective we are at even changing that to a great degree. At least what I've read, I think it's still pretty new.
The Tyler study, that was a good study. We did focus on particular drug mobilization. We actually, part of our study was kind of neat with that. We didn't find such a change in terms of reduction.
Yeah. And again, I think that's good stuff. But as you know, I can pull one study out from a lot of this stuff to say, hey, we need that history. And so it'd be nice when that stuff gets repeated, and hopefully we find that holds up, because it's nice to have some good data to say this is what's inside us. So I think when we have limited, those might be the kind of things we have to work with right now. And if the same is, if we see that, here's the evidence. Here's what we have. We don't have a lot else, so maybe this is what's best. We just got to make sure that we go back and look as more evidence accumulates and be willing to change what we're doing if things adjust. To various something else.
Okay. Yeah. And that's the Tony class, and then you say a Tony class is no better. The patient was no better.
I mean, it was no better than the other.
So if the upgrade of it, like the Tony class, was directed for finding symptoms, you haven't disproven that vision was the problem.
And again, you're going back to this idea. You're setting me up. You're putting me in a very bad situation that I can't prove. Like, I can't prove there's not a bunch of invisible elephants flying around this room. Right? They might be around here someplace. They're very small. They're quiet. You can't see them. And we can make the case, well, yes, they're there. I know that. So my point is, it's really hard to disprove something. That's why at the beginning I set it up to say, we're going to see, is this the evidence to support that this is the case? We don't have the evidence to say this is gone, right? We're making an assumption, right? And we're saying is we're going to assume I'm going to believe this until you disprove me wrong. And that's just really a tough way to do science. And we're just going to fail most of the time. So you're right. We can come up with any of these cases that I made. We can come up with the what if. What if this, what if that. I think my case should be is, and I'm going to talk about exercise in a minute, that we don't have any evidence that exercise really changes pinching significantly. It's just not out there. We can say we think it does. We can hope it does. Like I said, there's that MISTER study that showed that as you get fatigue or rotator cuff muscles, you get increased translation. So it's possible that could be a mechanism by which it does, but it hasn't been studied and looked at like that. So there's a lot of maybes. And it's okay to go on maybes, but why don't we be more accurate in our terminology while we're doing that and not say this is a problem caused by pinching? You're not convinced.
Well, it's not that. It's just I guess you're taking it from one end of it, and I'm looking at the other and saying, it's like you cannot prove that the theory of evolution. It's a theory. But model that
you can make the predictions the predictions you make on it are accurate all out. So it's just proven. Again, this is that idea of, can you ever know anything 100%? I would say I'm not 100% certain about anything, right? But we get to it when you get to a theory in science doesn't mean maybe. A theory is the top level. That's a law, right? It's a theory that the Earth is round, right? But there's all the evidence points. But it started out as a hypothesis, and it developed into got evidence. So, in terms of evolution, yeah, it's a theory, but this is not a theory. It's still a hypothesis. We don't have any evidence, and all the things that we would predict are not clearly predicted by the evidence that we have now.
This is more important question is, I'm saying it's not the model. So the model that we're using,
Yeah.
that guides our intervention.
Yeah.
And the question then really is, for me,
that's the plan, is to get this sort of, I just got a basic treatment to talk about.
Does that model work? Is there evidence to show that model is an effective model for how we treat?
And I would say no. We'll get to it. I mean, I would say that it doesn't. Well, let's talk about the exercise and see. And again, you probably won't be convinced after this either, and that's okay. But I think, again, that's why I knew it's going to be tough, because, again, we're coming in with, here's our model and our belief, disprove it. And that's nearly impossible. It's really difficult to do. And there's probably not evidence to make it solid, but I still think we can be more accurate, at least in our language and how we talk about it, which maybe would be helpful. Maybe not. Let's talk about treatment effects. Let's talk about exercise effects. So we look at it. Here are 3 systematic reviews. And systematic reviews are useful, but they sometimes miss the nuances. But I'm going to talk about those some, and then we can discuss a few of the a few other studies that may look at it more specific. There's very little information. Look at a study by Kelly in 2010. Looked at exercises of subacromial impingement syndrome. They used a lot of the common exercises. They used rotator cuff stuff. They used some scapular stability exercises as well. The articles they looked at had multiple different ways they did it, because there were several articles. So they found there was limited evidence to support the use of exercise. It didn't say there wasn't any evidence exercise works. It say the evidence is not strong. The exercise is effective. Problem is exercise effectiveness and the mechanism by which exercise is effective. It's totally 2 different things. And we'll get into that in a few minutes. So this article in 2009 by Cruz found similar things, that exercise helps with pain, but not so much with range of motion. And the biggest kind of go moment for this article was that they found that a supervised exercise program is no better than a home exercise. It's a little hard on us, but and then this last article here from Trampus found that there was moderate evidence for the exercise is helpful for this disorder, but adding manual therapy didn't really seem to improve the case. So there's evidence for exercise. The issue is we don't know the mechanism by which exercise works. So I have a couple articles here that start to get at that a little bit.
I think that's true. That's something that people that just rotator cuff therapy with non-traumatic drive did. Again, we're making that leap that so-called physical leap stairs, but you recommended physical therapy 75% of the cases.
Yeah, and I'm by no means arguing against exercise or arguing against physical therapy. I'm just looking at it as the mechanism by which we're assuming it happens. So I think there's plenty. For a systematic review in physical therapy, for systematic review to show there's some positive findings is pretty darn good. There's not a lot of things that we do that systematic reviews end up showing that we have a positive effect. Even if the studies are weak and there's not a lot. So I think this is not necessarily bad news, but if we look at it in the realm of what are these exercises doing, then it becomes a little more complicated, because most studies don't look at it. We don't know by the mechanism. Exercises have, general exercises has lots of different effects, specific and non-specific, and it's hard to judge. And we're finding more and more, if you look at trends in the literature, like you look at low back pain, exercise is helpful. Doesn't really seem to matter what exercise we do. So that would kind of imply that the mechanism may be non-specific. You can do stabilization exercises, or you can walk on a treadmill and do cardiovascular exercises. You can do yoga. You can do Pilates. You can do lots of different exercises, and they all work about the same. So that might mean that the mechanism by which exercise works is more non-specific. And that gets into a long conversation, but mechanism is the problem. So here's an article. Struess has done a lot of studies in this topic very recently. There's a couple articles that he wrote that I would have loved to include in my paper, but they came out afterwards. And he had the first, it was the first retrospective study that I found that he did last year. That came out after my search, and I didn't add it. It didn't really change the conclusion at all. But he looked at this article. He did 22 subjects with impingement syndrome, looked at outcomes of self-reported disability, scapular position, and movement. Again, so we talked about our exercises We look at scapular position and movement. We say if we can change that with exercises, then that will reduce the amount of pinching and lead to a better outcome. Right? So the problem I had with this study was, unfortunately, they changed a lot of stuff, which kind of bugged me. If you look at the treatment group 1, it did manual therapy, stretching, and scapular control exercise. They did a variety of exercises. Some of them were actually kind of hands-on positioning and getting people to move their scapular disc. The other one, they did manual therapy, strengthening, eccentric cuff exercises, and ultrasound. They were moving variables around all over the place. I'm looking at it, just changed one and helped us out. But the interesting thing I found was, actually in group 1, the group that had the motor control exercises, they did the best. They improved more than the other groups. But when they reassessed scapular position and movement, absolutely no change. It was the same. So they got the improvement, but it wasn't via the mechanism of changing the scapular motion. Now again, we can come up with, it's not evidence against it, we can come up with and say, well, maybe it changed metatranslation occurred, maybe it did other things that could have affected impingement. I don't know that. I can just go and look here and say that the case is not strong, that we can say impingement, that there's pinching going on and that metric is changing. One other study, this is a study mostly out of Iran. Again, they use this idea of exercise versus physical therapy, which bothers me. But they looked at 68 subjects. They looked at range of motion, pain, and scapular position and motion. They unfortunately did not do a measure of disability, but they had an exercise group, and the exercise group did a lot of the class things like Y's and P's and some balls and what, and some scapular stuff that we normally do. And then the physical therapy group, which is more modality-based and stretching. And it was different. They found no difference in pain between the groups. They found a slight increase in range of motion in the exercise group. And this time, the scapular motion did change. So now we have kind of the opposite, I would argue. Pain didn't change, and scapular motion did. So again, showing a disconnect, at least between that factor, the scapular position, and the response to exercise. So unfortunately, that's all really I could find for really studies that looked at mechanisms which would change, that did exercises that we would think would change a particular mechanism that we aim at for pinching. And then actually looked at, did that particular variable we're going after actually change, to decide if that was the mechanism by which the exercise was effective. Good. All right. So coming up here, pinching is normal, at least based on the limited studies we have. The correlation with corneal shape is suspect, and we definitely don't have the information to say it's positive. Posture seems fairly unrelated, at least based on the evidence we have right now. The postural stuff that we think would increase the pinching. Biomechanics that we think would increase pinching, not clearly associated. Treatments which are aligned with the prediction our model makes for us don't seem to line up with the treatments that we think will be most effective don't line up with the best outcome. So again, so that comes down to, well, if it's not pinching, what is it? And I think that's a pretty easy case to make. Right? We have tendon problems all over our body. Right? We have Achilles tendon problems. We have patellar tendon problems. We've got lateral elbow pain, tendon problems there, tendon problems in the hand. Not a single one of those do we say is because of pinching. Right? So why couldn't the same kind of mechanisms be happening here without pinching? I mean, to me, again, we're looking at where's the stronger case. We have this idea it could be pinching, and it's pinching and nothing else. It's pinching and what do we replace it with? And if we can replace it with a model that we already have, precedence for happening in other areas, it seems like maybe that's the better model to use. So again, it's not pinching, it's an excessive load. It happens, right? Then we get hypoxia that occurs. The blood flow is not very good. So we're talking about these intrinsic causes of the cuff. And there's lots of articles that talk about all these intrinsic factors. Some people have thought maybe there's a hypothermic effect, that actually you're building up heat, and that's destroying cells. You have chenocyte apoptosis which happens. The chenocytes tend to die off. And you have these cytokine and proteolytic enzymes that are there that are breaking down collagen. All which occurs in a normal tendinosis process. All this stuff happens there. So again, I think if you put these two together, it's hard to make a case that impingement, this pinching, is probably the most likely method. It could be, right? I can't sit here and say, look at this evidence, I know there's no pinching, I know pinching is not happening. And it very well could be that pinching is the problem in a subgroup of individuals. So maybe there's some individuals that pinching is the major cause. So, what do we call it? Where do we go from here? I would make the case that maybe rotator cuff disease is a more accurate diagnosis when we have evidence that the rotator cuff is involved. So if we use our special test that really simply identify that there's a problem going on with the rotator cuff, that's the best they can tell us about diagnosis. Why don't we just call it that? Or, I don't know that the disease is permanent, but that's fine. I mean, these rotator cuff diseases. Beginning the study, there was a study that looked at, there was a review that looked at this and they suggested rotator cuff. So you can cut lateral shoulder pain, you want to be left, or supraspinatus tendinopathy if we can get it to supraspinatus, or do a treatment-based classification system if we want to.
As part of it, when I wrote the study for the vortex, they go in and get into as part of rotator cuff.
Well, that's the issue. Is it's not like it's really, impingement syndrome and rotator cuff disease tend to be just called the same thing because we have no way to differentiate between them. Right? And so we don't know. I mean, maybe impingement is part of what causes rotator cuff disease. We know there's rotator cuff disease. We don't know there's pinching, so why don't we just take that off and just call it rotator cuff? Now, but if we do that, so we're going to go back to you guys over here, Gabe, and I've got some ideas. I don't know that it's going to make a major change in what we do. And maybe we just spent this hour and a half and I wasted time. We talked about this and it's like, why doesn't it change? But what do you think? If we were to say, let's just take away the fact of debating whether we should get rid of this terminology or not. If we make the assumption that pinching is not the mechanism by which this is happening, does that change how we're going to act in the clinic?
Trying to think of another area of the body that's tendon, particularly that stuff like that.
And that's why the idea of pinching was accepted because it makes sense, right? I don't think there is one that's really there. I mean, maybe I don't know if in the pelvic floor there's some areas where there's some entrapment between bones, and I don't think it happens a lot, but. You would have more experience with that, Gabe, with the Douglas.
Where we were coming along when we were taught, is exactly what you guys talked about. That the first power to these structures, these subacromial structures.
Okay.
Because of that pathology, you now is sensitive to that normal tension. And in fact, that tension may have been accentuated because the tendon became taken or there was swelling within the subacromial space. So now there was more pressure on those things. So we never talked about it in terms of, well, that's what caused the problem in the first place.
Okay, so you were retreating a result of the problem. That can be, I wonder how effective that's. Like again, you're treating the lymph to fix the ankle sprain. I understand that you're getting at, are you taking pressure off the sensitive structure? So why not just have them rest it, let that bruise calm down, and then you can go back to your pinching and you're fine.
That's what I think too. I think that as things develop, and the abnormal and and all these things that may have been causative, that we directed all of our focus strictly toward normalizing that movement and not directing any intervention for the patient that was that. We just thought that, well, if we eliminate the patient, that patient will heal itself very quickly and stop. And that may not be the case. The patient has to go back to addressing that.
I think I agree with you. I'm just going to repeat it real quick so people online can hear. So what you're saying basically is it might change in that we have to actually start, like we do at every other tendon problem, start treating the tissue versus looking at all these other factors around it. And I think at least we need to be going back to doing both, at the very least. But I think we've moved very far to treating all these other things, doing the posture, and that's why.
I think it adds further evidence to the fact that everybody gets the disease. Only some people get the sickness.
Yeah.
What's the difference? Everybody gets bolus. Some people become sympathetic. Some will do extensional. Some of them get better. Everybody gets arthritis. Some of them get left hand, they get better. So maybe the mechanical portion of it is only a small portion of it. You know, and you suggested that in that last slide.
Yeah.
There may be biochemical, neurobiological, psychosocial factors
that
we don't address at all that may play a larger role.
And that's where, that's where my research is taking me now, is really getting into more of this biopsychosocial model and treatment. And I think that's a big thing I look at for changing how we address this. I think for a long time as therapists, we've focused on educating patients based on anatomy, pathology, and biomechanics. And we've taken them, we said, oh, your back hurts, here's why, because your disc is out, you're moving wrong, it's extra pressure when you do this, extra pressure when you do that. And when we study that, that works horribly. At best, it does nothing. At worst, it makes the patients worse. They just don't do well with biomechanics. The back school stuff they study just doesn't work. What does work is talking about more about the pain system and more about psychosocial issues and how the pain system works and why sometimes there's pain and looking at pain as a threat and doing it all that way. So I think that looking at pinching as being maybe not the major mechanism, it allows us to maybe stop talking about that with our patients. Not say, oh, the structures are getting pinched in there and jammed and all these things that are likely to increase their fear avoidance, their pain catastrophizing, all of these things that we see in the back hasn't been studied in the shoulder so much, but I think we can probably make that correlation. So can we just talk differently about it and using a different name, and maybe would help at least those individuals who are at risk for those kind of catastrophizing tendencies, we can take that away.
Yeah, I think that also leads into the whole concept. So people know about a rotary, right?
Yes, I do know the rotary cup.
Right. So and that's a negative connotation. People know about anything else. That's like a connotation.
Very much so.
But if you tell somebody that, you get some mechanics that I think I can change in you, and I think I can help you, I think that's the connotation. That's the biopsychosocial concept. It helps people. And in there, we're not treating the medical diagnosis.
Most cases.
We're treating the impairment and those things. So if they're coming to us as an expert, and we put a positive spin on those biomechanics with some things that we know that possibly that if we can stay away from terms like, you got to defeat those things.
Yeah.
And I think that has
language matters, right? I think you're right. Is you can spin most of the things in a way that takes into account that. But again, we also want to be, at least my feeling is, and not that anybody tries to do this, is I've tried to do the best I can, be as most upfront and honest with my patients about the information. And I try not to go down routes that I'm sitting there and knowing the evidence of support that I have it. So I can stay away from biomechanics. I try to. And I'm using a situation where I try to assess the individual. If I have an engineer who comes in who's all about mechanics and moving, I'm going to talk that way with him because that's what they're expecting. If I have somebody who I feel is really hung up on the fact that, oh, my last week he told me my mechanics are wrong, or I'm really worried about it, and they're really caught up to that, I'm going to adjust myself and move them away from it. So I think it's also reading that patient, seeing in the majority of our patients, you can talk about mechanics and they'll be fine. There's those some that are going to maybe start catastrophizing from it. But again, I think you can spin it in a positive way. Well, then, and I would say I think I agree with that somewhat, but I think it's a very low bar. I think the problem with that is that people get better for life. And one of them primarily being kind, one of them being in the presence of a very nice person who cares about them, says nice things, and pays attention to them, and talks to them. And unfortunately, if that's what we hang our hat on, we're going to be destroyed as a profession. We're going to go away, and yes, there's some academics for that, but insurance companies are going to say, we're not paying for that. And if a patient is paying out of pocket, they're going to feel the same way. And so when we're seeing it, I mean, I think we're getting to where they're allowing us to do less and less things because there's no evidence for it. And they say, okay, we're going to take that away and not let you do it. They take that away and not let you do it. And I think we do have to look at outcomes, but if we don't tie outcomes to actual having interventions and making effect, then it's going to be difficult. And if we want to keep improving our ability to make effects, we've got to understand what's happening. Right? If it's more of this treating the tissue stuff, then we need to do more of that. We need to focus. And some of it is guiding research. We're going to go with our research as well. No, I think that's where they are now. But as we get more and more evidence, that's going to go more and more away. And
we could say that also is looking at physical therapy versus chiropractic optics. And what they found is that chiropractic actually save more money to the insurance company. But bottom line, what happened with CT is we tended not to follow the case, start, finish. We would start on a case and we generally get limited by what happens. Cascade effects like imaging and surgery, things like that, and they go back to PT and they add more on that.
And they go someplace else even, and you don't see them back.
And it's actually the test they cost. On average, later, just over $1,000 more for the patient with chiropractic. So I think in terms of wanting to get the patient better, I think it explains how you take it to utilize even if it's low bar evidence, there's actually studies that show this. That says that we seek to get better. You know, if we can at least cite some of that stuff, that patient with insurance who are valuable and again, understand what it says there.
And if you look at the cost of Medicare, man, physical therapy is like one of the top costs. I mean, we spend a lot of money on physical therapy.
Well, I think that's how they're pulling out from. They can't. Talking about actually the health outcomes, the sample size is so huge. Those are very sad studies, very sad studies.
In short-term follow-up.
Yeah, you for this diagnosis, with the person diagnosis, you get something particular. Okay, you get 18%. That's what you get.
Yeah, I mean, it's tough to get because research shows that when something ends up not so bad, a program, that a lot of their outcomes actually aren't clinically important different. Because what happens, gain more motion, gain more ability to do things, more strongly. Also, if you look at rotator cuff tears, the majority of rotator cuff tears are failure. Because if you look at some of the studies, there's markers that just look at MRI, and you still look like tears. Patients are okay. They judge their outcomes to be great if they consider failure. So you gotta let that time for that.
And at least the orthopedic literature is getting a little bit more into outcomes than the but yeah, you see a lot of them like that.
That's what the market thinks. Have that role to provide, whether it be the diagnosis or the outcome. So that's what the market thinks.
Yeah. But I hope that we can use this kind of information to guide us about finding the interventions which are most likely to help. And I think that we do need to go back to a 60 days. We need to watch what we talk to people. Is there anything else? Well, thank you for listening attentively. Thank you for, not hitting me up too much about trying to throw away this closely held diagnosis. Hopefully it was useful. Maybe some information. Thanks for coming.